Yeah.
We still wait a little bit before starting. Welcome to everybody. We wait until it's okay. So this is the Rare Histiocytic Disorders Steering Committee, and we have this first seminar, and I'm happy to welcome you to this seminar. I will first give you a few information before starting the presentation. I will first sorry, it does not work. Yes. So about the Histiocyte Society. So you I guess you all know about the Histiocyte Society, and we are more than 200 physicians and scientists throughout the world involved in this society. And the aim of this society is to improve the care of the patients and to contribute to the research on this topic. So we will also provide some educational session, and during the annual meeting, we also have this type of educational session. So for housekeeping of this specific webinar, it's quite easy. You can't speak during the webinar. Only the speakers will be able to speak, but you can ask some questions. You can use either the chat, as you see here. It's quite easy to use. And you can also use the Q&A question and answers. So you can use either one or the other one. So it's possible to have a real discussion. We will take care of your question and try to make it to respond to it. And we will also have some other webinars. So today it's on the rare histiocytosis, and the next one will be in April concerning Langerhans cell histiocytosis, and the other one will be concerning lymphohistiocytosis. And we start now. So the first speaker is Dr. Yusuf, who is a radio-oncologist and who has the difficult task to present us about when should we use radiation to treat histiocytosis and when should we not. So thank you for participating. I have to leave my screen, and then you can start when you're ready. And
excellent. Thank you all so much for inviting me to this panel and welcoming me to speak with you all. So we'll get started. I'll respect everyone's time because I know we're all busy too, so I'll try to keep to that 15 minutes. Exactly like you all are mentioning, I'm a radiation oncologist in Alabama at Birmingham in the US, and I'll be talking to you all about radiation as a possible treatment modality for predominantly non-LCH histiocytosis, just knowing that this is the topic of here. But given the greater breadth of data, I may talk a little bit about LCH as well, just to help kind of garner us. With this being a multidisciplinary audience, I always like talking about radiation as a modality since I'm sure most people are familiar, but not everybody. So we're talking about external beam radiation. So the figure on the left has an linear accelerator treatment table. So photons or X-rays come through the treatment table, go where we aim it. We'll talk about gray as our unit. So that's joules per kilogram or energy deposited in matter. So we use 1.8 to 2 pretty standardly, and that comes from both human and animal modeling, using kind of rams and rabbit testicles actually as a tumor model. So that was a dose where you were able to kind of sterilize the testicular tissue while keeping the skin from necrosing. So that kind of helped inform things for us. And then just briefly talking about LCH, we're not going to focus on this very much, but it is an area where radiotherapy has been used much more. Looking at our international guidelines, which many of you all are familiar with, and many of you all probably helped contribute to as well, radiation is listed as an option amongst others for select unifocal LCH, and particularly for bone lesions can be helpful. A lot of different experiences for this. As you all know, there's a German multi-institutional retrospective study, showed high rates of control. MSK or Memorial Sloan Kettering also showed high rates of control for bone-only disease. There's always the question, though, does this even need to be treated? And not every lesion would benefit from a local modality such as radiation. So we'll try to talk about that as well. Sorry, I don't know why that happened. But long story short, about 90% controls what they saw with relatively low doses of radiation as well. So 10.8 gray, and then for pediatric patients, less as well. So as far as the decision to treat or observe, there are a lot of factors you could look at. Is it symptomatic? Is the bone weight bearing? What is the risk of progression there? Could it be compromising neurologic function, that kind of thing? And then if you do need to treat, we also look at the age of the patient. That's going to be really important. And one of the things we'll talk about at the end of this discussion are potential late effects of radiation, which really will help kind of inform selection. So size, location, important. If something's small and accessible, curettage can be an excellent option. You can observe things that aren't symptomatic potentially. Surgery, in terms of radical things, I think most people are moving away from if it's going to be very disfiguring and that kind of thing. As far as radiation, if you've got an appropriately aged patient, it's unifocal, symptomatic, other local modalities are not preferred, can be an option. One of the things we mentioned is with the soft tissue component, usually the response rates are not as good. So we'll sometimes consider dose escalation, balancing toxicity as well. Briefly talking about non-bone subsites for LCH, the data is much less convincing here. Typically, our response rates are not as durable. And so, we've not used this as much in the upfront setting. Going back to Dr. Yahalam's experience from Sloan, they did have, 39 patients over a number of decades. About 13 of them had non-bone subsites. 3 of them had skin tumors, and 2 of those 3 recurred pretty quickly after radiation, and that's with higher doses as well. So as far as touching back with our guidelines, radiation is mentioned as an option for symptomatic unifocal skin lesions that are refractory to other kind of standard things like oral or topical steroids, interlesional steroids with imiquimod, and topical nitrogen mustard is another option. Not something we very commonly do, but can be a useful tool to have. So some newer experiences that have been published recently, Roswell Park out of New York has a case report, so not high-level evidence. I think that's important to mention too. One patient with Forsyth's disease, and what they saw was using a little bit higher dose of radiation than we would for bone LCH. They did have a clinical complete response that was durable at about 6 months. So for patients who are refractory to therapy, like your standard kind of therapy where surgery is not as good of an option, it's good to keep in mind radiation may be beneficial in that setting. Just to highlight the heterogeneity, other high volume centers like Dana-Farber, radiation is not very often used in the first line setting. So I think they had almost no patients in the first line get radiation for skin lesions, but more in the subsequent lines that are refractory. So just something to remember. As a toxicity type effect, initially when radiation was first discovered, it was all kind of superficial in terms of our energy. So the skin is the organ where we have the most breadth of experience of late effects. So it's almost over 100 years of data for that. So one of the things to highlight, the doses of radiation we're talking about are usually really well tolerated. So you'll see redness, sometimes see a little bit of dryness, but typically we don't see peeling or desquamation or wound healing issues, that kind of thing. One thing to keep in mind as we're moving towards targeted therapies like our BRAF and MEK agents, that can increase your risk of skin side effects during radiation at the same time. So I'm always very cautious if somebody's on that kind of therapy as well. Other things that radiation is not very much used for. So for unifocal LCH that's involving the nervous system, pituitary gland, typically we treat that more like multi-system disease. Historically, we've not had great outcomes with radiation here. Older techniques used whole brain and kind of less conformal things. The reason I wanted to bring up this series is there are some newer data from institutions like Stanford that are using a radiation technique called radiosurgery. Still non-invasive, but much higher dose radiation delivered very precisely. So even a few millimeters from your target, the dose falls off to 50%, 20% or less. And what they have found is, so small series, 5 patients, but for patients who had pituitary lesions with a median follow-up of 13 years, the control itself was quite good. To contextualize that though, most of these patients had diabetes insipidus up front and they did not see decreasing vasopressin requirements afterwards. So that's not a benefit we see routinely, which is a good thing to keep in mind. But for pituitary tumors that for mass effect are having symptoms like hemanopsia, things like that, if you want a volumetric reduction, they're refractory to systemic therapy options, not a good candidate for that, or recurrent, can't surgically assess it. This is a pretty minimally invasive technique you can use as well. So in general, as you know, for LCH, bone only radiation can be a good option. For non-bone subsites, we typically don't see as good responses, so we might consider it for certain things in the setting of multimodality therapy, typically at higher doses if we need to, but always in like a multi-D discussion too. Now moving on to what we want to talk about, non-LCH things. So Rosai-Dorfman is the first entity I want to talk about. With regards to the guidelines published in 2018, it mentions radiation as an option for things that are refractory or symptomatic, where surgery is not a great option. It's either recurrent after surgery or for whatever reason, if they're not a candidate for systemic options. One of the reasons why we don't use radiation often here is the historic data has been pretty poor. A review in 1990, so getting almost 3 decades old now, looked at 418 cases, radiation used in less than 10%. Of those, half of them had radiation doses, which are important. Only about a third of patients had any kind of appreciable response, so it's a CR or PR. We do have case reports in skin, orbit, and then larynx, but that's low-level data, and it's usually a 1 or 2 patient kind of experience. One of the larger ones published in abstract form is from MD Anderson in Houston, Chelsea Pinnix's group. Over 30 years, only 9 patients got radiation. And kind of similar to what we've seen, 44 had some meaningful control in field. So, and that's at higher doses than we usually do for for LCH. It was about 36 gray on average. New since 2019, the Yale group published a case report looking at cutaneous Rosai-Dorfman that was refractory to their kind of oral and topical steroids, used 30 gray with a good response at 7 months. It's important for me to be balanced. So I also want to talk about experiences that have not been as good for radiation. So I think the Mayo working group looked at their experience. So looking at skin or looking at Rosai-Dorfman in general, radiation was used for 2 patients, I think, from the front line with no response, 4 patients in the second line with 1 response. It was a 16.7% overall response rate. Dr. Potapenko was kind enough to share the picture on the right, as you can see, is a gentleman that he treated with a unifocal skin Rosai-Dorfman lesion. Received 36 gray, and as you guys can see, had an impressive response at 3 years. So it kind of in that higher dose, it may be useful. A few other groups have looked at treating areas like the mediastinum and kind of in the meninges with higher doses of radiation. Can be effective, but it's always important to keep in mind what your goal is in the context of, is this multi-system? How important is immune control in this area? What other options we have? Another meta-analysis looked at this with no real benefits. So the data here, not great either. Looking at Erdem-Chester, looking at our guidelines, generally this tends to be a multifocal process, as you know, and with standard doses of radiation we've used, not really responsive. So we don't often use this. The exceptions that mentions are, in situations where you need a rapid response because of symptoms, like, so if you've got cord compression, things like that, CNS symptoms, radiotherapy could be something you consider. One of the reasons why we don't do it is data from the Rare Cancer Network, which was published in 2006. Their response rate for 9 patients was very low, with only 1 patient with a bone lesion having response at a year. Interestingly, did have a higher dose, so 24 gray. And there are some case reports published since, including one from Ohio State for diffuse leptomeningeal disease involving this entity that used craniospinal radiation. Again, a higher dose, so in that 30 gray range, where they did have a response, had another recurrence pop up in the cerebellum that was resected and required further radiation after that. But this patient, at I think about 6 months, did die from non-CNS disease. So their thought was with a higher dose for palliation in that kind of setting, it might be a reasonable option where you don't have effective systemic therapy that can kind of penetrate intrathecally, and you don't have necessarily a surgical option either. There's a Japanese experience that used different doses of radiation as well for palliation for a patient with ECD. They found 30 and 10 to the knee was very helpful. 20 and 5 for cord compression was helpful too, but their 8 and 1 kind of palliative dose didn't really do very much. So a hint of maybe a dose response, but very low level data. Moving to the M group, this is even rarer. So again, our data is going to be largely limited to case reports, population level analyses, and then some review of case reports as well. This is from a study looking at 2 US databases that Dr. Goyle and the Mayo group published. Essentially 52 cases over about 10 years of Langerhans cell sarcoma. So again, rare. In general, what they found was patients, as you'd expect with unifocal disease, did better. Patients with non-risk organ sites, so if you didn't have liver, spleen, or a bone marrow involvement, did better. And then this is hard to say with much, authority. There seemed to be a univariable improvement in survival with radiation, but, we don't have local control. And I think with such small numbers, it's hard to know if that's, it's not the same level of evidence. But essentially, a local treatment such as surgery or radiation could be considered for unifocal disease here. Similarly, another systematic review looked at 66 cases. Single site did better than local regional, did better than distant. Multimodality therapy is what they recommended for well-selected patients, but to be honest, this was before next-gen sequencing, PD-L1, so I think that may help a little bit more of how we inform treatment decisions for these patients. Looking at, Dr. Goyle was kind enough to share a manuscript that's under review from the UAB Mayo Working Group. So, and this was looking at histiocytic sarcoma, Langerhans cell sarcoma, and then IDC as well. They had 8 patients with Langerhans cell sarcoma. Only 2 received radiation. But what was interesting, so this is for a patient who had essentially it was a retroperitoneal mass that had an NRAS mutation, was put on trametinib, had progression. In the meantime, had PD-L1 testing, which showed a high score, so they were initiated on pembrolizumab. Had a good response for 4 months or so, and I'll show you kind of the pictures on this slide. Developed after that some increase in anatomic size of the primary on that right retroperitoneum and a new left-sided mass as well. So at that point, the decision was made to come in with focal radiation targeting both those areas, which led to an impressive response at a year after. And I think now they published it with 2 years of follow-up without disease visible there. So maybe a role for radiation as part of immune rescue when you're using PD-L1 for well-selected patients. We'll talk more about that kind of thing too. Another group from Barcelona looked at using a similar approach, 36 gray of radiation to help salvage a patient who had been initiated on an older chemotherapy regimen. Moving along, I know we don't have much time. Other data is looking at histiocytic sarcoma, so 330 patients, perhaps will roll for local therapy for patients with localized disease. But again, patients with bone marrow and reticular endothelial system disease tended to do worse. Did better with chemo, but still we need room to improve and probably less of a role in the setting of diffuse disease for radiation. A couple of case reports about definitive radiation here for the thyroid and tongue base. So particularly if surgery is morbid, like base of the tongue, definitive radiation could be an option to consider for unifocal disease if other systemic options aren't great. I do want to talk a little bit about kind of just late effects of radiation. So I'm going to skip ahead a little bit. Particularly if you're treating a pediatric patient, I think that's where a lot of caution is needed. If you're skeletally immature, I think it's important to consider what the long-term effects of radiation might be. So for patients who are younger or kind of going, or prepubertal, we always worry about that, particularly if we're treating a long bone across the epiphyseal growth plate, vertebral bodies, for craniofacial centers. Those are things that it's really important to be careful at. We think about secondary malignancy as well, but that's something, at least in the available reports, we've not seen as much of. If you're treating cervical lymph nodes, be careful of the thyroid dose as well. So just talking about the spine, in general, if we need to treat it, one of our first decisions are, do we need to? We'll sometimes get pediatric musculoskeletal radiology available to see if somebody is skeletally developed or if they're still immature. There's a relationship between radiation volume and dose. The younger you are, the higher the dose you have, the more chance you have of either scoliosis if it's asymmetric or actual height changes if it's symmetric there too. As far as cranial facial hypoplasia, if you're treating a bone typically involving the calvarium or skull for somebody who's young, or even kind of the nasal septum area, the mandible, the maxilla, we know there's a lot of growth and completion there up to age 5, but even up to age 20. So those are things where it's really important, if you don't need to treat that area, to avoid with radiation as much as you can. Patients who end up getting hypoplasia from here often need a bunch of surgeries to have a reasonable quality of life. So in general, I tend to be really cautious and not offer pediatric patients radiation in this setting unless it's absolutely needed. Conclusions wise, I think is everything in rare diseases. All these decisions need to be made in a multidisciplinary fashion. As easy as a radiation doctor can to kind of lose the trees for the forest and only focus on one spot, one lesion may not be important if we're looking at kind of marathon approach for this. So exactly like you all have a team of specialists with expertise, it's important to create a coherent plan. LCH, high response rates with bone lesions, less so with non-bone. For Reside-Dorfman and Erdem-Chester, weaker data might be an option if it's refractory, symptomatic, not really amenable to other therapies. or having a contraindication there. If you're going to offer radiation and your goal is durable control, higher doses might be useful. What we'll sometimes do at my center is if you want bridging radiation more, so if they're going to go on a systemic therapy after, you can still use a low dose potentially for just an initial response to get symptoms better while you switch to another thing. For the malignant histiocytoses, similarly, if something's unifocal, symptomatic, surgery is not a great option, or the postoperative margins, you could consider radiation. If it's multifocal, maybe as part of a consolidative salvage kind of strategy if they're on other therapy or palliation. I'm going to stop there to respect everyone's time. Sorry for going over a little bit.
Thanks a lot for this excellent presentation. It's a wide panorama of what we can learn and see concerning radiation. So if there is any questions, please feel free to send the questions in the Q&A or so send it and we'll try to respond. In the panel, do anybody want to ask some questions about this? Usama, do you use radiotherapy when you treat your children or not? Or
I've never used radiotherapy until now. I mean, I haven't. No, we don't. We try to avoid it.
So in pediatry, it's still difficult to use it.
Yeah, but I have considered it once for. I've recommended it once for a case of Rosai-Dorfman of the orbit, localized, but I haven't used it myself. No.
Okay. Yusuf, you presented one case with pembrolizumab. Do you think that there could be a kind of ascopal enhancement of the response with these radiotherapy and checkpoint inhibitors, or is it just?
I think it's possible, but we're still learning a lot about the optimal radiation volume. I would say like things that can be beneficial, you can get increased antigen exposure from the radiation kind of killing some of the tumor. And we know at certain doses, you can have an uptake or an increase in the dendritic or antigen presenting cells. But I think the volume is really important in the timing as well. Where we've kind of seen limited efficacy is if we're treating a lot of the draining lymphatics, where you would expect kind of that effector T response to be trained. It's like pushing on the gas and the brakes at the same time where we abrogate that response. But if you're keeping your volumes very focal and say just treating the primary tumor and not hitting the draining nodes much, I think there are some entities where you can see a dual or synergistic effect. But I think one of the problems is, well, like, we were targeting PD-L1. We're still in the phase of getting like LAG, TIM, TIGIT, and those other kind of immune targets as well there. So, and then in terms of the dose and fractionation, there's still a lot of uncertainty. So I think we don't routinely see the abscopal effect yet, but I think we're all trying to work on learning how to better integrate radiation. I think part of it is volume selection, because if you're hitting the lymph nodes, I think that's not helping as much.
There's also a question in the audience. Is there any correlation between non-responders and the number of prior therapy?
I would say from my perspective, oftentimes when radiotherapy is used, at least nowadays, it's in the setting of refractory disease. So it's hard to get an apples to apple comparison. But I will say for some, like say for Rosai-Dorfman, even in the first line setting, it looks like the response rates are not as robust as we'd like, looking at kind of Mayo's experience there too. So I would say, I think there's probably some biologic selection, but I don't have great data for the rare histiocytoses that upfront radiation therapy works much better than in the refractory setting. I think we're limited a little bit by case numbers there.
Okay. Thanks a lot. Sheila, you want to make a comment?
That's a great question. I would say, as far as kind of like scoliosis with the dose to the single vertebral body, I would say Typically, it depends a little bit on the age of the patient as well. I know if they're under 6, the risk of something like that gets higher. There's a gender effect too for male and female patients, with some data suggesting if you're about to enter puberty. So I think that for boys, if you're about 11, or girls, if you're about 9, a little bit higher risk. I think what we've been trying to do is keep the dose under 15 gray, just based on some of the pediatric experiences. So I think like the risk is definitely lower with the low dose. So if I was treating a child, I think less than 7.5 or 7.5 gray is what a lot of people will use. And if you're treating the vertebral body symmetrically, probably less of a risk of scoliosis. I'd say there's probably a few different things to factor. I would say a lower risk for sure, but I think the dose and age have a big thing to play with that as well as target.
Okay, thanks a lot. So we are already a bit late. So we go. Jennifer, please.
We'll go fast. we'll
sorry.
we'll try to do our part fast. No, that's fine. So good morning, afternoon, and evening to all. Can you see the screen? Okay.
Yes, it's okay.
Okay. All right, so this is an overview of our work in progress on the NTRK1 histiocytosis. So just a very short introduction. We've known about NTRK1 rearrangements in JXG stemming from our initial small abstract series, but it wasn't until late last year that the group from Indiana University looked at a little bit larger series and found in 23 cases suggesting NTRK1 rearrangements in their solitary cutaneous JXGs, but they only did immunohistochemistry in the majority, and only 2 of them were actually molecularly characterized. And we do know from other rare reports that NTRK1 can be found in other disseminated histiocytosis. And so, as we discussed this at the last Athens meeting, and Jean-Francois and his group also presented their series, we started to come together and think that given this spectrum of so many unknowns with the molecular pathology and clinical aspects, let's pull this data together and start understanding it in a little bit more detail. So just with a mixed audience, so we have a quick schematic overview of the NTRK signaling pathway and mechanism of action. So there's actually 3 different transmembrane receptors, TRK A, B, and C, and they're encoded by the 3 different NTRK genes, NTRK1, 2, and 3, respectively. And typically, under normal conditions, there'll be a ligand binding and it dimerizes, and part of the tyrosine kinase family will phosphorylate itself and other pathways. And this one's unique in that there's 3 different pathways that the NTRK receptor can activate: the PLC gamma, the MAP kinase pathway, which we're all very familiar with, and also the PIK3 AKT pathway. And those are important for a number of different impacts on cell growth and development and survival, along with angiogenesis and cell migration. So we know that the NTRK 1, 2, and 3 are found in many different cell types, and it's also important in this day of inhibitor therapy that there are very potent NTRK inhibitors. We're also fortunate in pathology of having efficient immunohistochemical screening mechanisms with the pan-TRK immunostain that will pick up NTRK fusions 1, 2, and 3 with the same immunohistochemical marker. And some have shown that there's different staining, whether it be cytoplasmic or nuclear, depending on its fusion partner. So let's take a very quick dive into the pathologic aspect. So as I said, when we first started looking at this way back in 2018, we saw in this very small abstract series of 5 cases that were otherwise called JXG. They were in young boys, and they seemed to have a slightly different morphology than the typical JXG. There was a little bit more epithelioid appearance with plump cells with prominent nucleus and nucleoli, maybe a little bit of indented, but very few cases had that typical xanthogranulomatous appearance. They did all have this nice cytoplasmic staining with the pan-Trac immunostain, and there was some variability, light but definite staining with the Picarsic immunostain. So as we started pulling these together over the past couple months and really looking together through a pathology review, we started to see that there were some initial similarities, but also some differences, right? So there were definite cases with the more typical xanthogranulomatous, very lipidized appearance to these cells, many which had Teuton giant cells. And then there were others that had less lipid, maybe smaller, sort of the quote unquote early type lesions with lots of mitosis that scared some pathologists initially before further consult review of being other non-JXG lesions, just because they lack some of those typical features. But we started to see in this review together that there really is truly a wide spectrum of histology, from typical xanthogranulomatous to those that don't have the typical lipidized cell types, all while sharing this overall xanthogranuloma family phenotype, and that having monocyte macrophage staining, whether it be 163, CD14, CD68, or CD4, along with factor 13A. But what was uniform was the pan-Trac staining being very cytoplasmic. We haven't seen any nuclear staining, but with that cytoplasmic staining, it is of note that it can be quite strong to variable, moderate, to even quite weak, with still having that NTRK fusion. So I will, do you want me to stop, Jean-Francois, or keep going on this one?
Thank you, Jen. I will share my screen. Okay, so you I guess you can see it.
Let me stop. Yep, there we go.
Thank you. This is the series we have gathered together. We are put all the cases together to have a larger series. So you see right now we have 42 cases, 2 times more males than females, and they are mainly young patients, but not only. And we also have patients more than 50 years old. One critical point is that they all have skin biopsies, and in all cases it was skin biopsies. And Jennifer told you that it was xanthogranuloma histology. For most of the patients, it was a unique lesions, unique skin lesions, usually small. For 2 patients, we had several skin lesions, and we have 3 neonates with a different disease, I would say, but we will go on closer to this later. So this is the age and the sex of the patients. Concerning the localization of the lesions, you see that it can happen anywhere on the body, especially on head and neck, but not only, and you can see on any part of the body here on the slide. This is an example of a single lesion in a baby. So you see it's quite a small lesions. This is another example on a young adult, and she had several skin lesions. And this is I would say the more specific disease, which is in 3 patients, 3 neonates, 2 male and 1 female. They all have several skin lesions, large, sometimes large lesions, and they also have liver and spleen enlargements and some hematological abnormality, and all these patients had a strong staining with pan-Trac on the slides, of course. They all have different gene partners, so it's not related to a specific gene partners. Concerning the molecular of this disease, we had the molecular pathology in 33 cases, and you see that it's always NTRK1 but the partner can be different. We have a more frequent partner, which is IRF2, BP2, but we can see several genes, and there is also another gene, TFG, which is published for one case. So we haven't seen any other NTRK2 or NTRK3, but the gene partner is quite different. And there is no obvious correlation between the gene partner and the correlation on or the PAN and track expression and so on. Concerning the evolution of this disease, the cutaneous, strictly cutaneous disease, usually, well, some patients had R0 ablation and they had no relapse during the follow-up. Some patients only had R1 or a biopsy, a small biopsy within the lesions, and they had spontaneous regression. And concerning the neonates, the 3 neonates with multisystemic disease, which sometimes were very active disease, and for the pediatrician it was sometimes difficult to in the beginning, but they all had regression. They are all alive, and they all are regression. One spontaneous regression, one with chemotherapy, so the spontaneous evolution is quite good for these patients. And recently there was a published case. And the child initially had thrombocytopenia, coagulopathy, and hyperbilirubinemia, and during the 5 months, earliest months, it resolved spontaneously. But while they were seeing the child again, they noticed an eye involvement. And then they started larotrectinib, which is a targeted therapy against NTRK, and there was an excellent response to this targeted therapy. So all these neonates with multisystemic disease have a good evolution. Well, it's only 4 cases, but it's quite good. Concerning the NTRK specificity and sensitivity, so we have studied several patients. So for most of the patients, with all but one of the patients for whom we detected NTRK fusion, using RNA-seq, we saw the PAN-NTRK expression. There was only one case which was negative on immunohistochemistry, and the fusion was not in frame. So it's quite logical, because it was not in frame, we can't see the protein. And concerning patients with which were analyzed without NTRK fusion, they were all negative with the NTRK immunohistochemistry. So the specificity and the sensitivity of this staining is excellent, and I think it can be used for routine screening of the patients. Using RNA-seq is not necessary for screening. It's quite surprising that it's only skin lesions. So is there a bias? Did we only look in skin biopsy? Maybe. But when we look at the published cases, so there are only at the moment 8 cases with the molecular biology and the histology, and all these cases for which the information was available, so 7 on 7, also were skin biopsies. And in the recent publication, you see here where there was mainly immunohistochemistry, there were also only skin biopsies. So as far as we know at the moment, there were only skin biopsies for these patients. Even in some of the patients do have a multisystemic involvement. And in conclusion, I would say that it is quite large series, but I think it already gives an overview of what we will see in the future in these xanthogranulomas, in this quite specific xanthogranulomas with NTRK fusion. Histology is usually xanthogranuloma with various stages of evolution, sometimes small cells and sometimes xanthomized and two-tone cells. The staining with pan-Ntrac is excellent and can be used in routine practice. I think it's quite easy to use everywhere throughout the world. The Ntrac1 variant partners are quite various, so I guess we'll find some others, but we already have 8 different gene partners. All the patients had skin involvement, and there is a specific form, the neonates, with this multisystemic disease, which, although it's sometimes impressive, do have a good evolution. And one case has been treated with daotratinib and had a good response to it. So, and I would like to acknowledge of the colleagues who contributed to this series. It's well, the paper is in preparation, and I also would like to thank the member of the Histiocyte Society in France in the Histiocyte Society, and Cathy for contributing to this webinar. Thank you. I can't see the question, so if someone can see it, and I will. Is there any comments or questions? Otherwise,
Yes, Jean-Francois.
yes.
So we had recently a case of Rosai-Dorfman disease that is Ntrac positive at sick kids, and we actually have an abstract at the Histiocyte meeting in Athens. So it was clearly Rosai-Dorfman. It was not JXG.
And did you also see the fusion?
Yes, the fusion was the partner was IRF2, BP2, and Ntrac1.
Okay, which is the most frequent gene.
Yeah, but it was a skin Rosai-Dorfman, clearly, not a JXG.
Okay, okay, so we still have to learn about this disease.
So I think it's an entity that can have heterogeneous histopathological phenotype.
Okay.
And we saw that with even the ALK positive histiocytosis, that there were some cases that had rare cases that had an RDD phenotype that also strongly expressed the ALK, even though the majority of them were JXG. So that's not totally unheard of.
Yeah, I was going to make a comment about similarities between these patients and the ALK positive histiocytosis patients. It seems like there's similar groups, with the exception being that this Ntrac hasn't really shown neurologic involvement very much, it seems.
Right.
Yeah, and that's a big difference compared to the ALK positive ones.
Right. Exactly. Okay.
We have 2 questions in the.
I can't see it. Can you?
Yeah. So the question is, what clone of pan-Ntrac was used? And the other is, do you recommend routine evaluation of pan-Ntrac IHC in all histiocytosis, or are there any clues where your NGS fails, or should you be chasing by IHC? And this has come up in our RDD cases as well. Well, sometimes ALK is positive, or in other non-specific histiocytic infiltrates, ALK IHC is positive, and we can't do NGS because of low cellularity. Then we are stuck with what it means.
Jennifer, did you want to?
Yeah, I mean, we use the Roche Ventana clone for the pan-Ntrac. It's this EPR numbers. And I have been starting to just do a small panel with the BRAF VE1, ALK, and pan-Ntrac on the JXGs. They have different implications. And we use stains for a lot of different aspects. So I use a small panel with those 2 molecular immunomarkers, with a CD163 and factor 13A on most of my xanthogranuloma cases at this point.
Then there's a question of, do Ntrac negative systemic JXG spontaneously remit?
Mm-hmm. They can't. I mean, yeah. I'll let the clinical folks, but I know that JXG family in general, even in its systemic form, is much different beast than LCH.
Osama, do you want to talk about that?
Just
Since
to respond, one part of
Yeah.
the question, this is the clone that was used here. This is the, for all the cases, this is the clone that was used for immunohistochemistry. And
Yeah, most cases of skin JXG are non-NTRK, so this is a new entity, and most cases of skin JXG resolve spontaneously. We've had even cases of systemic JXG, especially of the soft tissue, that's resolved spontaneously.
the general impression is that the GXG will be, well, we are going to have more information about the molecular aspect of GXG. So GXG is probably some kind of heterogeneous disease with different genes involved. And maybe in the next future, we will have some different types of GXG, probably with a correlation between the gene involved and some preferential involvement, and maybe with the more aggressive or less aggressive, depending on the gene involved and so on. But we are still in the beginning of this story. We had the ALK, we have the NTRK. We also saw some other genes with fusion, SIK, RET, and so on. So I think we need to accrue the data and the information on this. Maybe we have to move on because we are late. So if you agree, Dr. Tobin, who is a neurologist at Mayo Clinic, and will take the last speak.
Thanks, John. Can you hear me okay there? You can't hear? Oh, great, super. So my name's Oliver Tobin. I'm a neurologist at Mayo Clinic in Rochester. And I try to see most of the histiocytic patients who come here in collaboration with our Mayo Clinic and University of Alabama Histiocytosis Working Group. This work was done by primarily by Dr. Nathu, who's one of our multiple sclerosis fellows, Dr. Nabila Nathu. And we're looking at patients with isolated central nervous system involvement with histiocytic disorders. So just to kind of give a primer, I'm sure most people are familiar, but neurologic involvement with histiocytic disorders is associated with significant morbidity. And this is the kind of typical location of involvement with Erdheim-Chester disease, Langerhans cell histiocytosis, and Rosai-Dorfman disease. And there's relatively high rates of diabetes insipidus, primarily in Erdheim-Chester and Langerhans cell histiocytosis. The diabetes insipidus, about 50% of patients can have a normal MRI, and not uncommonly people can have what is called idiopathic diabetes insipidus even up to a decade before the diagnosis of their histiocytic disorder. And just to give pictures to the words, this is essentially what we tend to see. So typically patients with Erdheim-Chester disease tend to have this globular mass-like lesion within the pons and cerebellum. The Langerhans cell histiocytosis can often have a very similar picture. I'm just showing here the calvarial lesions that we sometimes see. And then Rosai-Dorfman disease looks very different in that you tend to have more leptomeningeal disease, often mass-like lesions, extra-axial compression, like you see here in the cord. And often the initial diagnosis here is that of a meningioma or atypical meningioma. So typically, when we see these patients, the diagnostic strategy is to try to find a systemic target, skin, bone, perinephric disease, often in the sinuses. But sometimes we don't find a systemic target. And so the question that arose for us is there always systemic involvement in histiocytic neoplasms? And this is a practical issue for me because we get a lot of referrals for patients with enhancing brain lesions, and the diagnosis of histiocytic neoplasm is sometimes put to one side because there's no systemic evidence. So we used our Mayo Clinic EMR, which is both Mayo Clinic at Rochester, but also in Arizona and Florida and in our health system. So we can search all of the histiocytic neoplasms from 1996 to February of 2023. And we included patients who had a diagnosis of a histiocytic neoplasm based on nervous system tissue biopsy and an appropriate clinical phenotype. And it had to be isolated without any other organ involved. And they had to have sufficient evaluation for that. And that basically meant either a PET CT of body or a CT, chest, abdomen, and pelvis, and a nuclear bone scan. And they had to have sufficient records for us to be able to evaluate this. So one of the things that can be somewhat confusing in the literature is exactly what confuses or what constitutes nervous system disease. And we really wanted to focus it on central nervous system as opposed to intracranial. Now, we included dura and leptomeninges, but we excluded any bone involvement, so any calvarial involvement. We essentially said that that was multi-system, or any vertebral involvement. So we're looking at parenchymal brain and spine, leptomeninges, and spine roots. And so all of the cases were reviewed by at least 2 neurologists, starting at 2 and myself. So we reviewed 377 cases of histiocytic neoplasm, and 5% of those patients had an isolated histiocytic neoplasm. So you can see the breakdown here. There's proportionally a higher number of Rosai-Dorfman disease patients, so 6 of 46, or 13%, which is more than we'd expect from our general breakdown of histiocytic neoplasms. And this may be because it's easier to biopsy the Rosai-Dorfman lesions because they're superficial, because they often look like a meningioma and they're easier to get at. And neurosurgeons will be keen to go in and get that out. But maybe it represents something biologic about the disease. So the symptoms really depended on where the lesion was. Headache was the most common symptom, but weakness, diabetes insipidus, a smaller number with ataxia. This is the demographics of the patients, and the overall demographics looks fairly similar to our general histiocytosis patients that we see here. So the LCH patients were slightly younger, ECD in the middle, and Rosai-Dorfman disease slightly older. Most of our patients are white. That reflects our referral base. And we had a reasonable follow-up, a median of 26 months to be able to see if they developed any systemic disease subsequently. So the lesions that we found were fairly representative of multi-system histiocytic disorders involving the brain and spinal cord, with one exception that I'll show you. So these are the kind of typical patients with pituitary disease, with brainstem disease, and then with dural disease, kind of meningioma-like. There were 2 patients with the CSF1R, again, a function mutation, and these patients were very different. So these patients had an identical phenotype in that they had leptomeningeal enhancement, and then this very abnormal mass-like lesion within the coda equina. And you can see the meningeal enhancement here, and then the enhancement within the coda equina. So both of these patients were treated with pexidartinib, which is an inhibitor of the CSF1R pathway. And both initially responded to pexidartinib, but ultimately actually broke through. This is the rest of our genetic landscape of these patients. There's a wide variety of testing that was done because of the epoch and when they were evaluated. And then even within our patients who had next generation sequencing, there were several different platforms that were used, including an internal neuro-oncology platform, Foundation One, and Tempus. So a relatively low number of patients had BRAF mutation, and there was a higher number of other types of mutations found. So when I was listening to the radiation talk earlier, I was scrambling to try and see how many of our patients had radiation. So this is the outcome data. Anyway, I'll go back to the radiation. But basically, 1 patient died from complications of Rosai-Dorfman disease 3 years after the onset. And of the others, well, of the 18 that we have follow-up at 3 months, you can see that the majority of patients had some response. Now, there's a difference between the clinical response and the radiographic response, and this is common with neurologic disease, because if you have a destructive lesion and you make that lesion go away, and the patient may not necessarily get better. So if somebody has a myelopathy and you make the enhancement within the spinal cord go away, they may still be paraplegic. So you can undercall you can overcall a response and you can undercall a response because of the fact that a patient may stay the same, but radiographically they may improve. And similarly, they may stay the same, but radiographically the lesion may be slightly growing. So I favor using the radiographic response as the more telling response. And so, 12 of the 18 patients had some response and 5 had progressive disease. And as I said, both of the patients with CSF1R mutations initially responded and then progressed, one of whom developed a malignant histiocytosis with a TP53 mutation. So interestingly then, from the longer term follow-up, 3 of these patients developed systemic involvement, and one of those was cutaneous with LCH 6 years after the onset, and 2 of the patients with Erdheim-Chester disease developed systemic involvement relatively soon, so 5 months and 11 months after the initial evaluation. One of those was bone, and one of those was widespread lymphadenopathy. They weren't present on the initial evaluation. So our conclusions are that isolated CNS histiocytic neoplasms occur without systemic involvement. And some of these patients can develop systemic involvement later. And so the kind of practical implication for this is that if we see patients with persistent enhancing lesions within the brain or spinal cord parenchyma, that could be a histiocytic disorder, even in the absence of bone disease or skin disease. And also that if we see these patients, we need to follow them not just with MRI, but also with PET-CT scan, regular skin exams to ensure that they don't develop systemic involvement later. The CSF1R gain-of-function mutations that we found seems to have, there was only 2, but they had a very conserved phenotype with this mass-like lesions within the cauda equina. And so I'd be interested to hear others' experience of this mutation. Obviously, that's not the only manifestation of this mutation, but I wondered if anybody else had found that phenotype. And then it raises the presence of isolated CNS histiocytic neoplasms raises the possibility of a primary neural progenitor cell. So, it's possible that these neoplasms could come from microglia rather than peripheral myeloid cells. And so that's something that's potentially worth exploring in the future. So I'm going to stop there, and thanks for your attention, and thanks for being able to present today.
Thanks a lot, Oliver, for this excellent presentation. There's already one question in your audience concerning, did you exclude the children from the study, or?
Yeah, we did actually. So I'm an adult multiple sclerosis specialist, so we excluded pediatric patients. We wanted to focus on the adult component of the disease.
And I have also a question on did you exclude the malignant histiocytosis, or also because we saw some with exclusive brain involvement?
So we didn't, but I don't think we found anybody with primary brain involvement within our cohort.
Okay. Any other questions? Otherwise, I have another one. Well, I have sometimes some issues between the Rosai-Dorfman disease in the dural involvement of Rosai-Dorfman disease and the IgG4 involvement. What do you think? Do you just to be provocative? I wonder whether IgG4 disease of the meningia exists. What is your impression on this?
I can't think of a single case of isolated. I mean, obviously there wasn't in this cohort, but even with systemic disease, I can't think of any IgG4 case that we've had. That doesn't mean they don't exist, but I can't think of any case that we've had that's had IgG4 disease that looks like a Rosay-Dorfman disease. Ron or Gaurav, do you have any cases that you recall?
We have several Rosay-Dorfman disease with many IgG4 within the lesions, and sometimes the number of IgG4 is really high. And we also have some patients who were classified as IgG4 disease, and we reclassified as Rosay-Dorfman. So my question is, what's the overlap of these diseases?
Oh, okay. Yeah, thank you. Sorry, I missed part of the question, but I agree with Jean-Francois. Certainly, we do see RDD, IgG4 overlap with varying degrees, but not. I don't know if the question is about neurologic, but not in the context of isolated CNS disease or involvement. Sorry, I missed part of the question.
I think we do see. I don't think we have seen it specifically in neurologic diseases, but eventually, like a lot of times the criteria don't meet, the clinical or the IgG4 disease criteria. I mean, there are a lot of IgG4 cells, but I also wonder if those are just reactive IgG4 cells. I know the guidelines talk about IgG4 related Rosay-Dorfman disease. I don't know how different that is. So we end up actually just calling it RDD if it fits the RDD phenotype. And I don't know if Jen and Karen can talk about the path aspect, but that's an important question to explore overall. But in the context of isolated CNS or even systemic disease of CNS, not really specifically seeing anything like that.
Yeah, I think from my perspective, we often see an increased number of IgG4 positive cells in RDD, but I think we don't necessarily see other signs of systemic IgG4 related disease, the pancreatitis and those sorts of things. So I think it can be part of the inflammation in RDD, but it's probably not showing clinical signs of other cases that are bona fide IgG4 related disease.
Yeah, thank you, Oliver, for your presentation. I think what you have shown, I think, raises an important question about the patients that neurologists see, including you, MS. I think this may be just the tip of the iceberg. There are potentially perhaps a lot of CNS isolated enhancing conditions that may eventually or ultimately actually is due to histiocytosis, but never diagnosed. And I guess the challenge is, what are some of the signs that may point to neuroradiologists, about, when should you suspect histiocytosis, especially not all of these lesions are biopsied, or even, I think my understanding is even if you biopsy the brain, they may not look typical histiocytic.
Yeah, that's the biggest challenge really is that several of these patients need to be biopsied multiple times, and if you don't do the molecular genetics, it can be very difficult to secure the diagnosis. So you can just see a big inflammatory reaction without much in the way of histiocytic cells. So I mean, I think from the practicing neurologist point of view, I think looking at systemic disease, particularly PET-CT of body and skin evaluation, is often underused. And so that's what I encourage my colleagues. I think it's difficult. There's a wide differential diagnosis for persistent enhancing brain lesions and spinal cord lesions, but I think it does need to be on that differential. But many of those conditions also benefit from an evaluation with systemic evaluation, with PET-CT and skin evaluation. So that's become a routine part of our practice. I think our practice is probably enriched for difficult to diagnose persistent enhancing brain lesions, right?
Thank you, Dr. Tobin. And I think it would be interesting also to do a similar series in pediatrics, like isolated CNS histiocytosis in pediatrics. I know to see what's the natural history of these cases, if how different they are from adults, and the treatment and the response to treatment. We've had a couple of cases of CNS malignant histiocytosis. They don't do well, but other CNS histiocytosis do better than the malignant ones. So that's an idea for a study if someone would like to lead that.
Maybe a last question. Jennifer, did you see on the Q&A? There is a questions.
I mean, I think the question and I'm sure the other pathologists also know that RDD, I think, is one of the most challenging of the histiocytosis to diagnose, because those large RDD cells can be very obscured by the degree of inflammation and resultant fibrosis. So I have two cases of sinus possible RDD that look like there's a few RDD cells, but it can be challenging with that in particular.
Yes, we have several patients, well, not only in the brain, but anywhere with biopsy, rebiopsy, and so on. And years later, we finally receive samples, and we say yes. This is RDD, but it's sometimes it's awful because there is only few cells within the infiltration, so it's
Yeah.
very difficult. So maybe we are 5 minutes left. So unless there is some burning questions, maybe we have to stop. Thank you again for all to Mehran and to Oliver and to Jennifer for this nice presentation, and I hope we will have the opportunity to work again together, because in the Histiocyte Society we want to share all this data and to try to improve every day for our patients. So, hello.
Thank you.
And just a plug in the chat to remember the upcoming meeting in Goa, November 6th to the 9th. Registration will be coming out in April sometime.
Okay. So,
well,
goodbye.
Thank you. Bye-bye.
Thank you, Jean-Francois. It was a wonderful meeting. Yeah, thank you.